I'll address a few things about surgical management of the axilla. I think we should do this in 2 sessions, end of which I'll also show a video of sentinel lymph node biopsy. And so let me just minimize this. So in this talk, I think we should address the milestones of how the axillary management evolved, the anatomy, surgical anatomy of the axilla, assessment of the axilla, radiological assessment of the axilla, and evolution of the axillary management, and about axillary lymph node dissection itself, complications of axillary lymph node dissection, and the rationale, indications, technique, and evidence for sentinel lymph node biopsy, and then followed by what happens with a positive axilla and sentinel lymph node in special situations. So, it started off, if you see the first earliest of NSABP B04, it is one of the first trials with axillary management was axillary clearance versus no axillary surgery. And then it went on to axillary clearance, and then followed by a long period of axillary sampling, particularly in the UK. And then it evolved down to sentinel lymph node biopsy. And then now we're going back to square one and questioning the role for axillary surgery at all. So it's come a full circle. And so the Halstedian era, for a good 100 years, William Halsted actually described this theory of centrifugal spread. So from the tumor it goes to the lymph nodes, and from the lymph nodes to other parts of the body. So this was the Halstedian theory of spread. And so he emphasized the role of lymphatic permeation as a major mechanism of tumor dissemination. So therefore, axillary clearance, all this supraradical and radical mastectomy, modified radical mastectomy was practiced. And obviously this carried a lot of morbidity. And so they were cured. Many were actually cured of breast cancer, but they had such a poor quality of life with very significant lymphedema. So this was for over 100 years, this was the standard of care. And then in the 1948, Patey and Dyson described a less radical approach, to the extent that Patey's mastectomy is still done in many institutes, particularly in medical colleges. This is one of the most commonly done operations and taught to young surgeons as well. And this actually is a situation where pectoralis minor was divided and removed along with the breast specimen. Pectoralis major was preserved. So the pectoralis minor was used as a kind of landmark to show the levels of axilla, and it was removed along with the breast, level 1, 2, and 3, along with the pectoralis minor. This was a less mutilating operation, and the outcome was similar to that of radical mastectomy, but it still did not address the problem of lymphedema. And then in the early 70s, then all the adjuvant chemotherapy trials started. And along with this, in the 70s, Professor Veronesi and colleagues started a randomized trial aimed to demonstrate that the combination of local surgery and radiotherapy achieved the same results as those of radical mastectomy. So this was the quadrantectomy trial. After a median follow-up of 20 years, the overall and breast-specific survival rates were similar. So even in this quadrantectomy trial, axillary clearance remained an integral part of surgery. So from the NSABP trials, Bernard Fisher started one of the earliest randomized clinical trials, randomizing patients with surgery versus axillary clearance versus no clearance. We'll come to that a little later. So the surgical approach to the axilla in the management of breast carcinoma has been changing, particularly in the recent years. The concept of breast conservation now also applies to axillary lymph node conservation. So sentinel lymph node biopsy is a step forward in conservative surgery. So the avoidance of complete axillary dissection has a positive impact, particularly on lowering the risk of arm edema and arm mobility. So when indicated, sentinel lymph node biopsy gives very good assessment about axillary staging and spares the patient of unnecessary dissection. So it's axillary lymph node status, as we all know, is still an important prognostic factor. It's also an essential information to plan adjuvant therapy, and also very important for local regional disease control. So the surgical anatomy of the axilla, obviously superiorly the axillary vein. So we don't like to dissect above the axillary vein. Anteriorly the pec major and minor. Posteriorly the subscapularis muscle and the latissimus dorsi. And medially the serratus anterior. So this forms the axillary triangle. And we also know that the pectoralis minor muscle divides the axilla arbitrarily into 3 levels. So level 1 is the area lateral to the pectoralis muscle, minor muscle. So this, so when you do a mastectomy, when you reflect the breast, dissect the breast off the pec major, then you would come to the lateral border of pectoralis major, and then immediately below that will be the pectoralis minor. So lateral to the pectoralis minor, that area is level 1. So level 2 is the area of lymphatic tissue posterior to the pectoralis minor, and level 3 is the area of lymphatic tissue medial to the pectoralis minor. So and then you also have this additional interpectoral nodes between the heads of pectoralis major and minor. These are nodes called Rotter's nodes. And so when you do a surgery, it's important to identify the axillary structures to preserve. One is your axillary vein itself, and then you'd definitely we would not like to cause the damage to the long thoracic nerve, or otherwise known as nerve to serratus anterior. So if we damage this, it causes ringing of the scapula. It's quite unsightly. And then the latissimus dorsi pedicle, the neurovascular bundle, both the vein, artery, and the nerve are equally important, because any damage to the pedicle, the latissimus dorsi muscle is a very useful muscle, and it gets wasted. And it's also later, if it gets wasted and damaged, it's not available for a possible future reconstruction at a later date. So, and then preserving the intercostobrachial nerve preserves the sensation in the medial aspect of the arm, and also damage to it, particularly by cautery, by diathermy, actually causes a lot of neuralgia. And so therefore it is, if you have to cut, do a cold cut with a knife or scissors rather than charring it with diathermy. And then the medial and lateral pectoral nerve keeps the integrity of the pectoral muscles. So pectoral muscles again has a important function with the shoulder joint movement, as well as pectoral muscle integrity. Preventing wasting of the pectoral muscles is important particularly when you're planning an implant-based reconstruction, either primarily immediately or at a later date. Because if the muscles are wasted, then placing the implant becomes a problem, because until very recently, implants are traditionally placed under the pec major muscle, and if it's wasted, then it becomes difficult. So preserving the median and lateral pectoral nerve also becomes important. So the lymphatic drainage of the muscle is mostly to the axilla, and to an extent to the internal mammary chain also, particularly from the inner aspect of the breast. So what happens in the breast is, if you go back to your McGregor anatomy book, there is a plexus called subareolar plexus of Petty. So this SAPI, sorry. So this the lymphatics in the breast actually converge into the subareolar plexus of SAPI, and from here 1 or 2 or 3 chains of bigger lymphatic vessels drain into the axilla. So, and then a few might actually drain into the internal mammary chain of nodes as well. So the first echelon of nodes that drain the lymphatic from the breast is called the sentinel nodes. So we may have more than one in number, sometimes even up to 4, 5 in number. So, so the concept of sentinel lymph node biopsy involves identifying that first echelon of lymph nodes, first level of lymph nodes, and if then when you examine them, if they are free of metastatic disease, then the rest of the lymph nodes in the armpit are likely to be free of cancer cells. And that is the principle behind doing the sentinel lymph node biopsy. So how do we assess axilla? Axilla, of course, we all know, we do a clinical examination, and then more reliably, radiological examination, of which today I'm going to talk about ultrasound examination. So we know that from the NSABP trial, we know that clinical examination of the axilla is inherently inaccurate. So 27 patients who are deemed clinically positive, but actually after dissection found to be negative. So you take out the nodes, you think they are positive, so you do an axillary clearance, you take it out, send them for pathology, and the pathologist tells that all of them are negative. So that is about a third of patients. And about 2/3 of the patients, 39%, nearly 40% of patients who were clinically negative. So your clinical examination of the axilla, you don't find any significant nodes. And then those patients, if you do axillary dissection, about 40% of them end up being positive. So then this shows the inherent inaccuracy of clinical examination of axilla. So which is why now we rely more and more on imaging, particularly ultrasound. And it's important to understand what normal lymph node looks like and normal reactive node looks like. So whenever there is any infection in the draining area, any fungal infection in the nail bed or any cuts or even some scratches, whatever, all of these can lead to lymph nodes being enlarged in the axilla, in the upper limb, results in lymph nodes being enlarged in the axilla, and these are reactive. So the normal node look kidney bean shaped, rainiform shape, and they often have a thin, uniform hypoechoic cortex. I'll show you some images, and the hilum, what we call the hilum, where the lymphatic vessels and the blood supply enters the lymph node. That is the hilum, or otherwise called as medulla of the lymph node. This is usually fatty, and the blood vessels are usually only hilar in. So they come into the node through the hilum, and they exit the lymph node also through the hilum. So the afferent and the efferent blood vessels enter and exit through the hilum. Not only the blood vessels, lymph vessels also. So this is how a normal node looks like. So this, like I said, kidney bean shape, and or what we call as reniform shape. So this predominant, the center part of it is the medulla, which is fatty, and it's bright, it's isoechoic, and you see that thin rim of cortex, it's about 2 to 3 millimeters, and this rim is uniform throughout the lymph node, and it is not indenting, it is not bulging either inside or outside, and there are no, it is all smooth margins all around. So this is a very typical normal lymph node. So we describe this as a reniform node with thin hypoechoic cortex with a fatty medulla that is looking normal. So an abnormal node, what happens? The cortex becomes thicker, not more than 2 to 3 millimeters, can become eccentric. So it can bulge either outwards or inwards into the medulla. And the more it bulges into the medulla, it actually compresses the hilar fat, and it gets indented, thinned, or replaced entirely by cortex. And then instead of the blood vessels coming through the hilum, so you also find additional blood vessels all around the node, all around the capsule of the lymph node. So this is neovascular, neoangiogenesis. And sometimes the nodes become nice and round, what we call as globular or rounded node. So these are all signs of. So if you see here, this cortex is definitely thicker, not 3 millimeters, definitely 4 or 5 millimeters. And then it is producing, it bulging. It's like a rat bite, isn't it? Like the two teeth of a rat when it bites into a cheese. So this is called a rat bite sign, like that, and it bulges into the cortex. And if you see here, it's so eccentrically the cortex is thickened. It's not at all uniform, and it is compressed the hilum area into a small slit. So this is still the hilum, but it's compressed into a small slit. And here again, you see it's like that Mickey Mouse hat, Minnie Mouse hat type appearance. So if you remember that analogy, it's easy to recognize when you see again the cortex is thickened. It's actually not uniform, and there is a bulge into the hilum, and the hilum is compressed here as well. So here, if you see again, it's almost entirely replaced by the thickened cortex, which is all filled with tumor, which is small hilum. And here, very small slit, almost what you call as a globular node. Here again, a big globular node with a small slit of a hilum. So all this is abnormal node. Here, if you see this is irregular here, like small spiculations that you see at the edge of the node. This node is entirely replaced by the metastatic cells, cortex. There is no fatty hilum seen at all. This is in one section, cross section, and the longitudinal section. But the node here, if you see, it's all smooth. It is smooth here. You don't see any spiculations in the margin of the node. Whereas here, you see a lot of spiculations, and a lot of speculation is definitely not smooth. So what it indicates is that there is some perinodal infiltration. So these tumor cells have breached the capsule and started infiltrating the fat. So this is how the hilar vessels look like. So if you see, this is a kidney-shaped node. This is a cortical thickening, maybe reactive because it's little more than 2 millimeters, but it's uniform. And if you see, the vessels are coming through the hilum. So this is another normal node where in older people, as they get older, the lymph node actually becomes more and more fat replaced. So these nodes, remember, the size of the node does not correlate with metastatic involvement. The node can be 3 centimeters also, but it might be replaced with fat and may not have any metastasis. So here, this whole portion is the fatty medulla, and the cortex is thinned out into a small rim in the periphery. This again is a fatty replaced node, more likely in an elderly woman. So these are all abnormal nodes I've already showed you. So again, this is like one of those, Mickey Mouse hat type appearance, this kind of bulge that you see. This is the typical rat bite indentation. If you see, like that little indentation, like that rat bite sign, it's called. So this I've already shown. And these are examples again. Sorry, it got repeated. So this is how sometimes it looks on a mammogram. So just like, the concept of neoangiogenesis, there is, neoductgenesis. So in the lymph nodes, you would normally you won't expect any ductal structures within the lymph node. It should be lymphoid structure replaced by tumor cells. But obviously here there are a lot of microcalcifications. If you see here again on ultrasound also, within that hypoechogenicity, you see a lot of specks. So this indicates that the tumor cells actually try to form ducts, and what Teba calls this as neoductgenesis. So they mimic breast tissue there, form new duct cells, and they are very virulent and high-grade cancers. So this is what I meant by neoangiogenesis. So normally the blood vessels into the lymph node comes, efferent and afferent comes through the hilum over here. But what happens here, as the node gets larger, the blood supply that comes through the hilum is not sufficient, and it makes new blood vessels in the periphery of the lymph node. This phenomenon is called neoangiogenesis. And if you put a Doppler, you see blood vessels hugging the lymph node and infiltrating the lymph node from the capsule. So here again, you see this is that Mickey Mouse hat. The cortex is one, it's bulging inside into the fatty hilum. It's also bulging outward like that Mickey Mouse hat. And you see all the blood vessels in the periphery of the node. So these are all pathognomonic signs, radiological signs of metastatic lymph nodes. So obviously we like to prove that primary tumor with the core biopsy. For the lymph node, we'd like to do confirm histologically that it is malignant. So sometimes in our country particularly, we do find granulomatoous nodes, tuberculous nodes that can mimic metastatic nodes. So it's useful to do a sampling. So core needle biopsy of the node can be done, but some people are uncomfortable doing a core, understandably, because there's a lot of neurovascular tissue, and if you're not technically adept, then you could actually end up damaging there. So unlike the breast primary, then remember, no FNAC. Breast primary should always be cored. Core needle biopsy is a must for the primary in the breast. But for a node, FNAC can be done because lymphoid tissue, particularly metastatic node replaced by metastatic cells, yields well with FNAC. So if you're not comfortable doing a core, FNAC of the axillary lymph node is adequate. And this actually is useful to confirm whether there is mets or not. And based on this information, you could select patients for sentinel lymph node biopsy. So I was talking about NSABP-BO4 earlier. So NSABP-BO4 is one of the earliest trials. And so National Surgical Adjuvant Breast and Bowel Project. So Bernard Fisher was the man behind these trials, and they started in the 70s. And BO4 was a randomization between axillary surgery versus no axillary surgery. And this was based on clinical assessment of the axilla. And it was shown that mastectomy without axillary surgery was associated with an axillary recurrence rate of 17.8%, what was thought to be in clinically node negative cases. In contrast, in patients with positive clinical nodes on clinical examination, mastectomy with axillary clearance was done and was associated with axillary recurrence rate of 3.1%. So obviously there is a survival advantage in doing axillary clearance, and this was the evidence based on BO4 trial and in the 70s and 80s. So this was based on this. Then there was a clinical recommendation to do axillary clearance, and that was a standard of care until very recently. So for what we also understand is for no, when we looked at data subsequently, we also understood that in clinic node negative patients, doing axillary clearance does not improve survival and has a minimal impact of regional recurrence. But staging information was still essential for deciding adjuvant treatment plan. So the current recommendation is to do clinical and radiological node positive axilla should undergo axillary lymph node dissection. So this clinical comes with a caveat. Should be substantiated with radiological information also. So, and then the NCCN guidelines also recommend level 1 and 2 axillary clearance and a minimum of 10 lymph nodes. So that would be called an axillary lymph node dissection. So this recommendation was derived from a mathematical model developed by Kirikuta and Tosh in 1992. So a minimum of 10 lymph nodes to be removed and found negative to ensure a 90% certainty that the rest of the axilla is negative. This is clearance, mind you. Anything less than 10 lymph nodes is not called a clearance. It's considered incomplete, either because it's poor surgical technique or it's because the pathologist didn't assess the axilla properly. So the exceptions, sometimes you would have done a very good job. The pathologist also looks very carefully, but you still might not find 10 lymph nodes. The exceptions may be due to neoadjuvant chemotherapy. Sometimes when you give neoadjuvant chemotherapy, it sterilizes that area so much that you don't actually discern the lymph nodes at all. So the nodal yield may be very low. And in elderly patients, generally there are lower number of lymph nodes. And if the patient has had any prior axillary surgery, then of course the nodal yield might be low. So all of us know the consequences or the complications of axillary lymph node dissection. So it increases the risk of seroma. Sometimes seromas keep forming for up to 3 to 4 months. I've seen seromas for even a year, up to a year. They form, it gets walled off, and the walled off it gets lined by epithelial layer, and that continues to secrete fluid. So unless it's poured out and you put a you may have to drain again or excise the cavity. So otherwise it doesn't settle down at all. If you keep aspirating, it keeps accumulating. So that is one of the rarer complications. More often, seromas last about a month or two. Usually, it should settle down in 2 weeks' time. So, and then inadvertently, one might injure the long thoracic nerve. There might be LD pedicle damage, latissimus dorsi pedicle damage, and medial and lateral pectoral nerve damage resulting in wasting of pectoralis major muscle. And then there might be a restriction of shoulder movement, particularly in diabetics. So these are all the potential complications, but the one dreaded complication that all surgeons worry about is lymphedema. So they are at a lifelong risk of lymphedema. It may develop even 10 years after surgery. And the incidence ranges from about 5 to 60%. The risk of lymphedema is higher when more nodes are removed. Where the nodal burden is high, where there are a larger number of node positivity is higher. In obese women, the risk of lymphedema is higher. When there is a post-operative infection, then the risk of lymphedema is higher. And when there is, repeated seroma, long-term seroma, the risk of lymphedema is higher. And when there is lymphangitis in the arm, so a woman, she does some gardening or injures herself with the kitchen knife or sustains burns while cooking. So all of these can contribute to infection in the arm, lymphangitis in the arm. Recurrent episodes of lymphangitis also leads to fibrosis and lymphedema. And axillary radiation adds to the risk of lymphedema as well. So when we do a clearance, we do give advice about prevention. Exercise is a very, very important part of preventive routine. So the exercise, now we're talking about prehab, no, not just rehab. So it's just like you use the TriFlow meter to exercise the lungs before any major surgery. You would actually start talking to them about exercise before even you operate. So this what we call as prehab, not just rehab, prehab. So when you counsel them for surgery and give them all the preoperative instructions, when they are well, when their arm is, even before surgery, you teach them the arm exercises and ask them to start straight away, even before surgery. And then skincare routine. So tell them to use moisturizers, avoid cuts, injuries, bruises, use a glove when they do gardening, be careful when they do nail paring. So all of these might seem very simple, but unless specifically told, they might not actually bother with it. And then it's important also to maintain optimal body weight. Avoid arm constriction. It's even the clothing, they might have a very tight arm sleeve. Then jewelry, rings particularly, wristwatches, bangles, all of these things can cause constriction. And so also avoid exposures to extreme temperatures. And wherever possible, ask them to use IVs and injections in the other arm, and avoid checking blood pressure on the operated side. So all of these instructions should be given to them, and given to them in writing in the language that they understand, and also told verbally. And we usually also tell one attendant also. So this is very important in preventing or lowering the risk of lymphedema. So coming to sentinel lymph node biopsy, this was designed to minimize the side effects of lymph node surgery, lymph node dissection, but also we must not compromise on cancer control. So and auxiliary assessment for treatment purposes. So this outcome should be equivalent to that of axillary lymph node dissection. So as I told earlier, the first node in the regional lymph node basin that drains the primary tumor reflects the tumor status of the entire nodal basin. So the first set of, not just first node, I would say first set of nodes, first echelon or first set of nodes. It may be 2, it may be 3, it may be 4, or even it might be 1. So these first set of lymph nodes that drains the primary tumor reflects the tumor status of the entire nodal basin. So if those set of lymph nodes are negative for tumor cells, then the rest of the lymph nodes also will not have the metastatic spread. So that is the idea behind sentinel lymph node biopsy. So this is what I talked about earlier. All of the lymph nodes, lymphatics converge onto the subareolar plexus of Sapi. From here, there are 1 or 2 big chains that go into the axilla. So this is the tumor, and you can actually see some chains going into the axilla. So if you pick out these first set of lymph nodes and send it for clone section or HPE, depending on the facilities available, and this gives us a clear picture about metastatic involvement. So how do we identify the sentinel lymph node? So sentinel lymph node is identified using a radioactive material, technetium pertechnetate, or blue dye. So blue dye, what is available easily in our country is methylene blue. So although in the US they use isosulfan blue, in Europe they use patent blue. So patent blue is not available here. Isosulfan blue we can get it done, but methylene blue is easily available. It's cheap and it's very effective. It costs about 60 rupees for 10 ml. We only need about 2 ml. And so in the last so many 7 or 8 years, I've used only methylene blue without any problem. So it is usually combined, dual technique. More recently, other techniques have come about using ICG, indocyanin green. There is this ICG camera which actually ICG the dye is injected intravenously, and this is picked up. This is injected in the breast, or it can be injected intravenously to check the integrity of the flap also. So for the sentinel lymph node, we inject it into the breast, and you see actually with the light switched off, you actually can image the lymphatic channels. You can actually visualize the lymph node with the lymphatic channel, and you can actually identify the number of the lymph nodes also that pick up the ICG, and then you can do a targeted lymph node excision, send it for pathology. So this is a more recent technique. It's cost effective too, and it's now easily readily available in India. And there is a learning curve to it, and one has to get comfortable doing it. It's ideal to do it with the breast conservation surgery. With mastectomy, there is still some challenges. At least I was not entirely comfortable. I should give it another go exploring it. But I commonly use a blue dye either alone or a combination of radioactive material and the blue dye. So the radioactive isotope is often injected in the nuclear medicine department. So it cannot be done outside of the nuclear medicine department. It needs a specific license. So this should be available in the institution, only then that is possible. Then you need a gamma camera, a small handheld gamma probe that is available. So using this gamma probe, we actually identify the hot node. And using the blue dye, we identify the blue colored node. So using both techniques, the sensitivity of is very high, is high. So identification rates are high using both the techniques. So the node is identified by color and by the radioactivity. So these are removed and then sent for frozen section to examine for presence of metastatic tumor cells. So injection, where do we inject? So different routes are available. So it's either peritumoral injection, intradermal injection, subareolar injection. All of these have been explored. So what is currently used, what is more commonly used by most of us now is the subareolar injection. So as we already alluded to, the lymphatics in the breast converge onto the subareolar plexus of Sapi, and from here a few large chains move towards the axillary area. So therefore, injecting the subareolar area, you can be very sure that you will be able to identify the lymph node in the axilla. So agents, I already said that we use radioactive technetium pertechnetate, and we use methylene blue. So where ICG camera is available, ICG also can be used. So the timing of injection. Blue dye, we usually inject as soon as the patient is induced and massage for about 3 to 5 minutes. Radioactive iodine, radioactive isotope should be injected in the nuclear medicine department. So it should, usually the department opens around 8 o'clock, and we send the patient to get injected at 8 o'clock, and then soon after they get shifted to the OT. So we start operating by 8:30 or 9 o'clock. So sometimes you can inject in the morning and then operate in the afternoon. It all depends upon the coordination between the nuclear medicine team and the OT team. So, but blue dye can be given just after the induction. So earlier, before the technique got crystallized, we were doing preoperative lymphoscintigraphy routinely. So after injecting the radioactive isotope, the nuclear medicine people will also do an imaging to show us the number of nodes and possibly the location of the nodes with the scintigraphic image. But as we got comfortable doing this procedure, now we don't do this procedure at all. So it reduces the work burden for the nuclear medicine physicians. So they just inject and send the patient to us, and we would do the surgery straight away. So, and then there is a particular method in doing the histological assessment as well. So this, I will just skip this. So we avoid doing the peritumoral injection. Subareolar is better because one disadvantage with peritumoral injection is particularly in the upper outer quadrant tumor, where the axillary lymph node will be close. There will be a shine through effect, and you may not be able to differentiate the primary tumor activity with the lymph node activity. So therefore, there might be a little bit of a confusion there. So injecting radioisotope or blue dye is always done in the subareolar region. So I will just skip this bit. So this we already talked about, and so there is a like I said, we inject after the induction and then go scrub and come back. By then, you go straight to the axilla to do this procedure first. So there is a rapid transit time from the nipple to the subareolar area to the axilla. This it was very obvious when we did the ICG method. So when you give the ICG and then immediately switch off the lights and switch the camera on, you would actually physically see that dye moving, and it's that quick, very rapid. So injecting in the subareolar avoids the shine through effect. So again, do we use only one single agent or double agent? Single agent is only methylene blue or only radioisotope, or use methylene blue and radioisotope. So obviously doing double agent is better, it's more foolproof. So the gamma probe is something like this. You get a handheld camera. This is put in a sleeve in a plastic cover, and so this is how you get the counts. So I will show a video next time when we do this in continuation of this. And when you make when you do a breast conservation, you make a small skin crease incision in the axilla, and you need only about an inch of incision, about 2 centimeters. And when you open the clavipectoral fascia, you see the lymph node, nice and stained blue like this. So there were many series of central lymph node trials, and so some of the earliest trials were the identification rates with single agent was about 86% and dual agent about 90%. And using dual agent, that is both radioisotope and methylene blue, the false negative rates were lesser. So there were many others, like, all these trials have become redundant now because this has become, because all these trials paved way for it to become the gold standard. Now, for a radiologically node negative patient, sentinel lymph node biopsy is the standard of care. In the West, we end up doing axillary dissection and where in a node negative situation, and then you harvested 20 nodes, 25 nodes, and it comes back to say pathologist says all the nodes are negative, then you could actually be taken to court for doing an unnecessary axillary dissection. It's not come to that yet in our country, but it will be very soon. So a lot of patients now are very well read, and they come back and ask us, are you doing sentinel lymph node biopsy or are you going to remove all the lymph nodes? Very standard question that I get asked. So again, timing, we said that, talked about it earlier. So this is how we inject. Just lift up the nipple areola and inject in the subcutaneous plane about 2 ml of methylene blue. It's important not to inject intradermally, because if methylene blue in the dermis can actually cause a bit of reaction in terms of it can necrose, the skin can necrose. So it should be just under the skin. And under the skin is where all the lymphatics are anyway. So in the skin, it may not actually, intradermal, there might be skin necrosis, and it may not actually reach the lymphatics also immediately. So this is how, when you put a retractor like this is how you see the node. As soon as you open, you actually see a little lymphatic channel leading up to it as well. So when you find one, always look for more lymph nodes. So one useful landmark is the lateral border of the pec major. So as soon as you make a nick, you identify the lateral border of the pec major, open the clavipectoral fascia and that plane closer to the lateral border of the pec major. And when you open the clavipectoral fascia, the axillary fat pops out. And then if you do some blunt dissection there, you could actually see the lymph channel and the lymph vessels. So always look for more nodes. And when you're using radioactive isotope, then it becomes easier. So with the blue dye, it is only visual. With radioactive isotope, you have a count, an objective count of radioactivity that you see on the machine. So it should be, you should have at least 10% of the count in the injected site. So in the subareolar area where you actually inject the radioactive isotope, nuclear medicine people would have injected there for you. So you do a baseline count in that area first. So you get a number, say 20,000 or 10,000. And to that, in the axilla, you should get at least 10% or more, if not more. So that would be your sentinel nodes. So if you have a count of 10,000 in the subareolar region, and you put your probe in the axilla and take out the lymph node, identify count in the axillary node should be 1,000 and above. So then it is defined as a sentinel lymph node. So then you pick these hot, when the radioactive count in the node is high, these are called hot nodes. It indicates that these are the first echelon of lymph nodes. So the radioactivity gets trapped in the lymph node when through the lymphatic vessels, it enters a lymph node, and beyond that, it doesn't get filtered and goes to other lymph nodes. So those first echelon of lymph nodes traps the blue dye, traps the radioactive activity there. So therefore, you see it blue, and you also put a probe there. You see that it beats, and the count is high. So with that, those two as indicators, you remove those nodes, just those nodes. You don't need to remove a lot of fat around those nodes, just those nodes, and send it for pathology. And while you wait for the frozen section, complete the rest of the procedure. So that is how it's done. So the pathology, assessing the lymph nodes, again, the ASCO gives clear guidelines about how the central lymph nodes should be examined. So these nodes are frozen. So they are frozen and they are sliced at 1 to 2 millimeter thickness. And then you quantify the deposit. Deposit more than 2 millimeters are considered as macrometastasis. Deposits between 2.2 to 2 millimeters are considered micrometastasis. Anything less than 0.2 millimeters are called isolated tumor cells. So your clinical decision also depends on all these categories of assessment of lymph nodes. And then, so this I would skip because this is not done anymore. And so the concept of central lymph node biopsy started off with melanoma. It started in 1994 with Armando Gugliano. He adopted this technique from melanoma. He started using it for primary breast cancer. So and then by 1997, they refined the technique was crystallized, and the patient criteria and all the results and the false negative rates, the identification accuracy rates, the false negatives rates were all published, and then it became the standard of care. At least 10 studies reported comparable good results in patients with a negative central lymph node biopsy and no axillary dissection, with an axillary local recurrence rate ranging from 0 to 1.4. So this is about 46 months follow-up. So this is a very good, very acceptable axillary local recurrence rates, comparing a negative central lymph node biopsy and no ALMD. So the identification rate and accuracy improved with surgeon experience. So you need to do at least about 30 cases, and the learning curve improves. When you start the program initially, always combine a central lymph node biopsy along with axillary dissection. So you can actually validate your technique, and the pathologist also validates their technique, and you actually should have a accuracy rate of about, identification rate of about 98 to 100%, and false negative rate of less than 5%. So these are some of the trials. So I think I should stop here now, and we will do the rest of it later. So I'll do the NSABP later trials later, next Monday.
Any comments or any questions on today's session? Please feel free to comment.
I'll show a video next time, so that will help in.
Anyone would like to add a comment? So there are no comments, Selvi. Shall we close the session?
Yeah.
Thank you all so much for your patient sharing, and the sixth session, the breast education group comes to an end. And the next Monday, again at 8 p.m., we'll be ready with the seventh session. Thank you all so much.
Thank you. Thank you. Bye.